Suppose for a disease, say tuberculosis, a new test, T, is developed. The manufacturer first measures the sensitivity and the specificity of the test. For that, they select, suppose, 1,000 patients confirmed of having tuberculosis and 500 patients confirmed of not having tuberculosis. The new test, T, is employed in all 1,500 patients. Let's form a 2-by-2 table. Suppose the test came positive in 900 out of 1,000 tuberculosis patients, which are true positives. 100 are falsely negative. Also, suppose test became falsely positive in 100 out of 500 normal people. 400 came truly negative. 2-by-2 table is completed. Sensitivity is defined as capacity of the test to detect correctly those having the disease, which is 900 out of 1,000 or 90%. Specificity is the capacity of test to detect correctly those who do not have disease, which is 400 out of 500 or 80%. Now the manufacturer can claim that the sensitivity of the test, T, is 90% and the specificity is 80%. Now the test is available commercially for clinical use. As a clinician, you receive a patient with suspected tuberculosis and you perform this new test. The test comes to be positive. What do you say to the patient regarding the diagnosis? What is the probability that the patient has tuberculosis? To answer this, you should know the positive predictive value, or PPV, of the test. Similarly, if the test comes negative, what is the probability that the patient does not have tuberculosis? For this, you should know the negative predictive value, or NPV. Now let's learn to calculate PPV and NPV. Suppose you have 1,000 patients of suspected tuberculosis, and you employ the new test in all 1,000 patients. You also need to know the prevalence of the disease in your population. Suppose the tuberculosis prevalence is 60%. This means, out of 1,000 suspected patients, 600 will have tuberculosis, and 400 will not have tuberculosis. As the sensitivity of the test is 90%, out of the 600 tuberculosis patients, 540 will have the test positive, and remaining 60 will have false negative results. Similarly, as the specificity of the test is 80%, out of the 400 patients without tuberculosis, 320 patients will have true negative results, and remaining 80 will be falsely positive for tuberculosis. As seen in the 2-by-2 table, out of 1,000 suspected patients, 620 patients will have positive results for the test, and 380 will have negative results. Now let's calculate PPV, which will be 540 true positive out of 620 total positives, which correspond to 87%. This means, if the test comes positive in a patient, you can say to the patient that you have 87% probability of having tuberculosis. Now let's calculate NPV, which will be 320 true negatives out of 380 total negatives, which correspond to 84%. This means, if the test comes negative in a patient, you can be 84% confident that the patient does not have tuberculosis. Let's see the effect of prevalence in PPV and NPV. Suppose the prevalence is low, say 10% only. Out of 1,000, only 100 people will have tuberculosis, and 900 will not have. Now let's fill the 2-by-2 table by true positive, false positive, true negative, and false negative values. You can see clearly how the PPV has fallen to 33% only, and NPV has increased to 98%. If disease prevalence is low, PPV decreases and NPV increases. That is, the test will be better in ruling out the disease when it comes negative. Similarly, if the disease prevalence is high, PPV increases and NPV decreases. That is, the test will be better in confirming the disease when it becomes positive. Now let's see the effect of sensitivity on PPV and NPV. Suppose the sensitivity increases to 99%. Let's fill the 2 by 2 table with 80% specificity and 60% disease prevalence. You can see that PPV changes only little, while NPV now increases to 98% from 84%. So high sensitivity means NPV is increased, means disease can be effectively ruled out when test comes negative. Now let's see the effect of specificity. Suppose the specificity increases to 99%. Let's fill the 2 by 2 table with 90% sensitivity and 60% disease prevalence. You can see that NPV changes only little, while PPV now increases to 99% from 87%. So high specificity means PPV is increased, means disease is effectively confirmed if the test comes positive.